All right. Once again, hi everybody. Thank you so much for joining this meeting. And let's continue. So, welcome to Free Health Shadowing. And across this meeting, we have closed captions to accommodate all of you for all abilities and needs. And if you have any ideas about how we can be more accessible, feel free to email us at info@prehealthshadowing.com. Also, make sure to save us as a contact and keep us out of spam. So you can join our email list just to know about the upcoming sessions. If you want to stay on the loop, you can sign up for our email list, but along with that, you can also follow us on social media. And here are some of the social media handles. So I would just like to know where you guys are all calling from. So PHS headquarters are in California, and I'm talking from San Jose, and I'd just love to know where you guys are from. Feel free to type it in the chat. Illinois, Texas, SFO, Colorado, New Jersey, Oklahoma. Ooh, Canada, Vietnam. Pretty diverse group, guys. Thank you. Additionally, if you're interested in being part of our pre-health shadowing group, you can register as a volunteer. This is 100% remote, so you can do it from the comfort of your own home. And apart from this, if you're interested in joining our leadership team, we're also recruiting for that, and that is too 100% remote. And you can apply for that on our website, and the link is also in our chat box. And here are some of the roles that we have in the IT department, grants, fundraising, and much more. And apart from this, if you have a role that we don't have listed, but you think it would be a good addition to PHS, you can just let us know. And you can sign up using this following link. If you're a high school student, you can join our high school training program, which is offering both leadership and healthcare education for pre-college learners. And for that, you have to fill out the interest form, which is also on our website. Once again, donation is the foundation of PHS, and we would really appreciate if you could give a donation. Even if it's like $1, it's really, really helpful. But we also understand that not everyone is in a position to donate. So if you'd still like to contribute to PHS, you can volunteer. Throughout the session, you will have the opportunity to ask questions to Dr. Ann. You can do this by typing your questions on the chat, and you could also raise your hand using the little Zoom raise hand emoji, and our co-host will ask them during the question Q&A. Make sure to take good notes as our pre-health shadowing assessment is available after this session, where you could just do a little quiz just to get a certificate for all the time you volunteered with us today. It would be really great if you guys could turn on your camera just to duplicate a real life environment and just making the session more engaging. Thank you. And now I'd like to pass it on to Dr. Ann, if you could just talk more about yourself and your career
I
experiences.
get to talk about myself. Okay. And I do want to just say hello to everybody and say from California. I'm calling you from Pasadena. I'm working from home this afternoon, which is sort of a new thing that stuck after COVID, which is nice. But also, I think that the Zoom platforms and remote platforms have made it a lot easier to share knowledge and experience with other people around the world, which has been a really nice thing. And I slightly sometimes think about things I might do in my future or when I scale down or retire or something. And one of those would be maybe opportunities to teach internationally or even go precept internationally and sort of see how things work in other countries. So I followed a pretty traditional track for my era, although it was in an era where there weren't as many women in medicine, but it also wasn't at all ethnically diverse because I trained like 30 plus years ago back east. And went straight through from college to medical school and right on into residency and fellowship in my specialty of hematology oncology, which is I focus exclusively on blood cancers. I'm a full-time academic, been a professor for 30 years. I'm currently associate professor at University of Southern California. So my interest in medicine probably was predated by being interested just in science and nature and so on. I loved animals. I thought I wanted to be a veterinarian. And then my aunt and uncle were what you would call back then missionary doctors. Now you'd call public health or global health physicians that worked at the Albert Schweitzer Hospital in Haiti for 20 years. And prior to that, I'd worked in parts of Africa and continued to consult for certain international relief organizations on um, international infectious diseases and weaning foods for children at risk in countries that have high infant mortality. And so I suddenly rethought, what I was interested in and thought, wow, it would be really cool to be a doctor maybe and do something hopeful and meaningful to my fellow human beings. Maybe, I love veterinarians too. I still like animals, but somehow that suddenly struck me as a lot more meaningful. I actually went to visit them at their work in Haiti at that time, this a long time ago, and really just like saw on the ground how they were trying to do actually teach people at the ground level and local people how to do like simple interventions for health care in their own country and become health advocates without necessarily any special advanced training, and just see like such practical interventions that could have such huge impact on people. So that's where I got interested in medicine. My father was a research PhD in pharmaceutical research, and that probably skewed me a little bit towards the scientific end of things. Later on, when I went interested, but we had four siblings, and I'm the only one who went into science, so that was just me. I think I was as much influenced by my aunt and uncle's interests, and their their daughter, my cousin, also went into medicine and has worked on medical ethics, and also has taken trips abroad for international medical relief and so on, sort of continuing on her parents' legacy. So my aunt is now 93 and still a very vital person who still would like to make some points about how we could do better, more equitable care here in the United States and at a community level, using some principles of what they did in small places in other countries and so on. So I wish I could get her on to talk about her life trajectory too. So then during medical training, I took an early interest in the immune system, and I loved my blood cancer course and that blood system course. And that's sort of what got me interested in the path that I eventually followed. And I still do quite a lot of teaching of that in this day and age, and I do it also with both patients, students, patient advocacy groups, and so on. So I'll just give you share a little bit of my most commonly used slide set for, when I'm talking to a wide variety of people. I'll talk to people about their immune system and go through often a teaching explanation, even with my patients, about what their immune system is and how complex it is, and how we both have problems with cancers arising from it or the lack of its activity, or how we now manipulate the immune system with our really powerful immunotherapies. And that actually is now my area of specialty, is cellular immunotherapies like CAR T cells and bone marrow transplant and so on. Bone marrow transplant has been, you know, in there for a long time, is one of my interests, but sort of sharing that both at the medical student level, the patient interface, because patients really, do want to share in their decision making, and understanding their immune system and how we're using it to treat them is really helps them understand what they're taking, why their cancer occurred, how we're trying to control it, and so on. And they also usually get a little bit fascinated by how we have all these designer drugs like antibody therapies and now antibody drug conjugates that go in there and help them, kill their cancer cells. So I'll often show them, I'll just do a little quickie animation here. I often show them this demonstration of how one of the drugs that I'm going to put in them is an antibody drug conjugate that acts like a smart bomb. So it sort of has a chemotherapy attached to an antibody that's going to go and seek out only their lymphoma cells and be taken inside the cell. I always tell them I have a lot of analogies that I like to use over time, that this is like the little Star Wars and the starfighters that go enter the Death Star. So they go in through some little avenue into the Death Star, they get taken inside, and they release the chemo inside and blow up the cell from the inside. So patients really like to sort of visualize that. That gives them something to think about when they see something being put in their vein and wonder what the heck, what is going in me? What's going to happen to me? And I'm showing like you can visualize these antibodies going to your cancer cells really directly and selectively and going inside them and blowing them up very selectively. And then I talk to them about some of these other antibodies I use, which I'll come back to maybe when I talk a little bit more about my work. But I think it's very helpful to, I just keep these, slide presentations on my OneDrive on my phone so I can just like be in a class, a workroom with my residents or interns, or I can be with my patient and say, well, here's how it works. This is what it looks like. This is what it's doing. And I think that teaching aspect has been a big part of my life, not only the reason I'm in academics, but how I enjoy interacting with my patients. So, to give you an example of my day, I have, an academic clinician, so I'm a clinical professor of medicine. I sort of share teaching responsibilities, direct patient care. I do outpatient and a lot of very intensive inpatient care. And I also run clinical trials. So I don't run a lab myself anymore, but I am interacting with people who run a lab, or more importantly, I am taking on new trials of things that have been developed through good laboratory translational science. And now I'll be the first person offering these to people to try as their new drug. And some of these will be very new drugs that have never been tested in a human being before. So those would be phase 1 trials. Some of them have shown a little signal and seem to be safe enough to go to the next steps, and they'll put them into a larger phase 2 trial. And then we'll have drugs or immunotherapies that are looking really promising, and we'll take them into what we call phase 3 trial, where we'll test them against either our old standard versus this new treatment or the old standard plus this new treatment, with or without that, and seeing if it really lives up to its promise. And so that is really an interesting thing to do. And it's also very gratifying to see some of the things I worked on years ago are now sort of standard drugs in this area. For example, the antibody I first showed you a little picture of is now sort of like one of the most standard things we ever use in all of our blood cancers, which are mostly B cell oriented. And this was an antibody. The target was developed by my old boss back east. The molecule and the design of it was eventually successfully created by someone who had been just like 3 years senior to me. And then I was the young investigator of many that was involved in testing this in people. And I do remember one of my senior colleagues when I first moved out to USC, who's sort of a strong character, and he said to me, "Yeah, Anne, really, you're going to treat cancer with an antibody." But he sent the first patient, and that really got everything off the ground, and it's become an extremely important drug in all of cancer medicine, but particularly started in my field because the blood cancers tend to be very responsive to immunotherapies. And so we have proof of principle usually in my field, and then they try really hard to find something that'll work in solid tumors. And we have some successes, but they're usually the most successful in the blood cancers because they're the most responsive. And so that's gratifying. And then I've had others, you spend a lot of time on trials that never work out. There's lots and lots of things you try. They seem like such brilliant ideas. They're so smart. The lab work that was done on them to design them, so interesting. There's always something new going on in my field. But, only one out of 50 things will ever pan out to be a useful drug that you're going to use in people. But it's fun to be part of that, development process. Sometimes I'll have people who are actually making, a new CAR T cell in the lab, and I'll be the clinical person who will write the clinical protocol for them to take this into patients for the first time, and so on, and advise them on that. So that is, sort of the research side of my work. It's not the primary lab research or wet lab research, as we call it, but the final translational step of, look, can we really try this in people and see if it works? And that part's very exciting and gratifying. Um, on the clinical end, so I might have sort of 2.5 days of clinic per week when I'm not on the inpatient service. That's still my standard schedule. and I'll spend a lot of time trying to teach patients about their disease and educate them, especially when they've had a new diagnosis. So I might, for example, take them into, hold on, let me grab a picture of like the lymphoma.org website. I might take them to the cancer.gov site, for example, and show them, while I'm explaining their disease, also show them some visual things that will allow them to understand this better and also be able to go back to this resource or maybe get a glossary of terms because everything's, so unfamiliar to them. And also, especially with the cancer.gov site, give them a site where they can share that with their family because sometimes they've brought one family member or friend with them, but they haven't, not everybody's there and everyone's asking questions later. Um, I often even encourage them to record our visit. People aren't supposed to secretly record you, but I say, hey, if you have other family members who want to hear about this, you can either have them on the phone live with me, or you can, record it on your voice recorder on your phone and share it with them later. But sometimes more simply, I just tell them, let's look at the cancer.gov site. I'm going to put it on your phone, or if I'm introducing a new medicine, or for example, a new designer drug, I'll open it up on their phone and say, let me take your phone and I'm going to look this website up on your phone for your drug that we're going to use. And it shows you the mechanism of action and all the side effects and everything. And then you can email this to yourself and your other family friends, so you have the information in your own hands. Because a lot of our push in medicine is to have what we call shared decision making with patients. But for me, that also begins with shared education of the patient. And, we only have so much time in clinic to teach them about it, but now they can go and review this instead of just putting the word lymphoma in Google and getting, an undifferentiated mess of information which might not be relevant to them or even inaccurate, with all the false information out there. I try to take them right to the best sources that they can explore from there. So this is why in my area and many areas of medicine, but particularly in cancer area, there's lots of resources that really are run by patients. They're patient advocacy websites that are really very disease specific. And they'll give these patients really a handle on what their blood cells are, what their lymph system is, what their immune system is, general, with a lot of visuals and particulars for them to sort of get a grasp of what they're going to go through, or what's going on inside their body. And I think a lot of them, feel they come away from that with much more calmly understanding how they're going to take on this disease and so on. Because if they have to do it all by themselves out there in the information systems out there, they really get lost and they get sometimes overwhelmed and bewildered. And it really helps to give them at least a few starting points of higher quality information in addition to what I'm telling them. Because I don't know if there's a famous scene in that movie, 50-50. I don't know if anyone's seen it. It was out several years ago, where as soon as the doctor starts talking to him about his diagnosis and showing him the CAT scan images on the computer, the patient just sort of his vision blurs, and the sound of the doctor's voice sort of blurs. And that I think that's an experience that a lot of patients have, that it's just too much at once for them to absorb. And so I always, encourage them to have an advocate with them, a friend or a family member or someone who can, help gather information with them and, let them just focus on what they need to do and so on. So those initial points of contact are very important. I also appreciate, at least the cancer site from the national government, NCI, at least has one other language that this is available in. So I can give them this kind of information and hit the button in the right, and it will be entirely in Spanish. And I think in this day and age of AI, I'm sort of surprised that we don't have it in all the languages we would name, because in my setting in Los Angeles, at least a quarter of my patients don't speak English, and they speak, one of, you know, commonly I might use a translator in 4 to 6 different languages in a day. So we usually use a live video interpreter, and especially when it's a new diagnosis or when we're talking about chemotherapy or immunotherapy, At least in Spanish, I know enough medical Spanish that I can even correct the interpreter if they didn't, get the concept of something right, even though I don't know any grammar because I didn't learn it properly. But, we used to be very comfortable just letting families translate and realize in some cultures, there's with the word cancer, they're going to avoid using that word or maybe not even explain what we're saying, which, there we have a lot of interesting ethical discussions of like how far is that okay to do? What's our Western ethical philosophy versus Eastern? Are we, or other cultures, are we forcing that on? But at the very least, we have to have a translator so that we know what I'm saying is being translated. I can ask the family if they don't want me to say certain things, and I'll say, well, here's how I'm going to say it. And, at a certain point, I have to say at least this much, or I would be, under informing the patient and so on. So, we do try to use professional translators for that reason to make sure we have a uh, full communication and understanding with the patient. But I still have the family in there because the family can sort of see from that patient's micro expressions and they're looking towards them, like, what does this mean? The family also gets the nuances of the emotional interpretation of the patient of what's being told to them and so on. And I think I think it's important to have them there too. Um, so so on the clinical day, I might come in. I don't start really early. I'm not a surgeon. And patients have to come in and get their labs done first. And usually, since I'm a hematologic oncologist, everybody has labs first. They come into my office, they see my nurse first, often see my nurse practitioner first. We have a busy practice. There's a lot of complicated things and treatments we have to do. We have lots of, lab work that has to be interpreted every time we see a patient. We've got to change their chemo orders, we've got to hold their chemo orders, we've got to look for toxicities. And so it's very helpful to work as a team, as MD and NP, or PA. And, the more complex the practice is, the more often you'll see that kind of pairing for sort of a division of labor. And our nurses get sort of special training as well. My nurse practitioner might like handle writing all the chemo and entering. They're not written, they're pre-written chemo orders, and then I have to check them off and so on. And then we, go through the labs and we discuss those with the patient and whether they need growth factors to boost their white count or whether their kidney function's going off, and we need to investigate why that is and whether they need blood transfusions or whether they're doing pretty well with their labs. And we go over their PET scans. If they have lymphoma, we'll look at all the scans and see where their response is and what areas are concerning. And I often, share all that data right with them and prefer they be sort of coming up and sitting or standing next to the computer to see it with me, to share that with them. I also, really again to try to get more patient involvement in the decision making and participation in their care. Usually like them to be signed up for those portals for their labs so they can understand their own labs too and go over those with them, particularly if they get their labs done outside of our facility. And even simple things like, and you should do this with your parents, if they have an iPhone, I make them fill out their medical ID and put their information on their serious illness and the, medications they're taking that are potentially important if they got in a car accident or went to an emergency room, and also our contacts so people know how to contact us and so on. And so that kind of little sharing of responsibility both helps me, but also helps them that I'm thinking about them more globally in terms of how they take care of themselves. We get into, in the oncology area, you're managing the whole patient. So one of the things I've, find interesting is I'm not just focusing on their cancer, I'm focusing on their whole life and quality of life, their work, their kids, whether they have to stop going to school for a while, how's their relationship with their wife going and so on, their personal lives and so on, and what's being impacted emotionally or physically. And so that's always part of the global treatment of the patient with cancer, especially in my case, where the cancers are likely something where they're going to have a good chance of cure or living a very long time with them, with the blood cancers. So you have to really take the long view in how I'm taking care of this person and trying to make a low barrier for them to feel comfortable talking about something, even, their libido or how their things are going in their relationships and so on. Um, because, there's often things that will get in the way of someone taking good care of themselves or following through, taking care of themselves. I've had people who are taking 20 supplements, but they're also drinking a lot of alcohol in a week. And so you have to sort of have these calm discussions of like, well, if we really want to take care of your health, we need to like reduce all these things you're putting in your body. They're going to interfere with your chemotherapy or getting well or helping your immune system, you know, put itself on the right track, but you want to do it in a not too lecturing patriarchal way so that they trust that you're doing this in their both best interest. I had someone who's a very sophisticated person, but his list of supplements was like unbelievably long. This is just last week, new diagnosis of lymphoma. And they're doing this all to be healthy. But I've said, but you developed this cancer on all these things that you're putting in your body. And you're drinking 10 drinks a week. And you're doing edibles. And I'm like, that's a lot of stuff to put in your body. Let's put that all aside right now. Okay. Let's just focus on getting this cancer under control and then do the really natural, healthy things. Send you to the farmer's market, get you out exercising, teach you mindfulness techniques, things like that, that are really going to be important to your global health and the health of your immune system. So that kind of partnership with their patients and the advocacy is not just, some people have asked me on the far other end of the scale, like, how can you do this when you're in oncology? Like, how could you like stand to deal with these immediately or ultimately put in some case life-threatening illnesses? How could you, wouldn't you be depressed? And like, it's really quite the opposite. Most of the people I know in my field are very positive people, and they are, and even the palliative care physicians that I work with realize when someone's up to the, ultimate challenge in their life, they're facing a disease that could be fatal to them. Anything you do to help either cure that disease, help them live with it better, help keep it from coming back, or at least make those remissions last as long as they can, that's gratifying. But even when you can't do anything to stop the biology of that disease, you're sort of there for them, a strong shoulder, the person to talk to, the person to be ready to relieve their distress or their discomfort, the shoulder they can lean on through that whole process is still very, very gratifying. You feel like you've done a lot for that person, even when you can't biologically turn around that disease. And sometimes patients are most thankful just for that support, even when you couldn't do much else about their disease. It's interesting how that, gratitude is often the most strongly expressed. Like we felt so desperate, and even when we couldn't fix the medical situation, you were there for us through this all the way to the end. And that, you do take a lot of sense of personal purpose from that in the cancer field. It's not all just about the cure. So, and you end up getting, very connected to patients over the years and their families. I usually, don't go and do separate socialization with patients until they're long years out or so. But I do have some that I always meet at the ski area. We try to go to the top of the mountain and take a picture every year because he's the longest survivor we have so far of CAR T cells, and who's one of the early people willing to go into the trials for that. And I just sometimes like to pop into some things that we do together for sort of a little mutual support. I tell them, I don't need presents. A lot of patients want to bring you presents, and some cultures they feel they have to bring you a present every time they see you, every single clinic visit. And but I say the best present is sort of getting your, I don't know, your holiday card with a picture of you and your family, and knowing that you're thriving. That's the thing I love to see, and I usually cover my office cabinets with you know birthday, holiday, Christmas cards, and so on, to just show pictures of my patients that are back out in life and thriving and so on. So I do find that aspect of my work really, really gratifying. Another third big part of my job is teaching. So I mentioned, I teach the patients themselves, of course, and then I have responsibilities for teaching because I'm in a university setting as a professor, and I have a couple modalities of teaching. So um, as you've probably seen on, TV shows and so on with medical shows, there's, the medical students and the interns and the residents and the attendings. And so most of the medical teaching after your first 2 years is really on the wards, on the, actual direct patient care. So I would have a few, I have a few lectures per year and so on. And that's, one modality, of course, but a lot of it is based on so that might be sort of more like what I was just showing you with my, immunotherapy lecture. We'll go through those slides, we'll explain the immune system, we'll talk about all the cool, you know, immunotherapies and CAR T cells and so on that I use. But that's a pretty small amount of the teaching. The main teaching is seeing patients together, and that's mostly going to be on the inpatient side. I know in other fields you would also rotate out with an attending a lot in their clinic setting, and actually as a pre-med or whatever, that would be a common setting where you would be shadowing in a clinic. And I do sometimes have the already enrolled med students come over and shadow me in my clinic just to see what oncology is like, since they think they might have some early interest in that area. But the teaching on the inpatient wards is pretty much going around as a team, seeing all the sick inpatients, discussing their problems, listening to their presentations, sort of saying, what are we going to do next? What do you think we should do next? What's your differential diagnosis? What's your plan? Why are you doing that test? How are you interpreting that test? And that's the sort of Socratic method of teaching. It's very important for people developing their own clinical thinking skills. Medicine is definitely a self-learning kind of profession for the rest of your life. It's a very fast-moving field, so you do have to sort of practice that on your own all the rest of your life. And the best learning usually is in the sort of interactive setting, person to person. There's only so much you learn for just reading it on a page or listening to a podcast. It's applying that knowledge in a dynamic setting that really is more likely to stick or make you curious about what else you need to know and so on. You always remember the cases you've had better than the ones you haven't had. So I enjoy that a lot. I, in particular, teach at a sort of higher level of training. So I would say the main focus of my teaching is of hematology fellows. So these are folks who've been through medical school, 3 years of residency, and are now in their specialty training. And I also do a lot of teaching of fellow oncologists out in practice. So I'll do continuing medical education programs and conferences that recap the really big conferences that I go to, like American Society of Hematology, and we distill out like the best. Like last weekend, I did one where we're doing the highlights of ASH. So we'll do the best 3 abstracts from each of, 12 fields, and I'll do the section on lymphoma or multiple myeloma and present that to an all oncologist audience. And then they have a chance to, ask questions or even come up to me afterwards and ask about their cases. And that's a sort of area that I get into because of my long-term practice in a specialty area, that I have a lot of physician to physician consultation at the level of people who have already been in practice for many years. So I was just on the phone 20 minutes before this with a physician from Nevada, from Las Vegas. About a fifth of our patients are from Las Vegas because it doesn't have a sort of higher level university medical school there. And so they'll come down to Los Angeles. And so they're asking me, well, she was on these 3 chemos in a sequence. You saw her for consult a month ago. We're getting ready for CAR T cell, but she's having trouble right now. Her disease is progressing. What would you do for her while we're waiting for that? We discussed using this newest designer bispecific antibody and said, can you get that in Vegas, or does she need to come down to Los Angeles for me to give it to her here? And we're working with the center. And I got a question there. What happens if you don't agree? Well, they don't have to do what I tell them, but they have called me because they want guidance. Okay. And so they're usually calling me to give them some advice on how to do that because my area is I'm so subspecialized in my area. Just like I don't know breast cancer, I would need to go ask my breast cancer colleague. A general oncologist out there in the community has to know so much. I mean, oncology is a gigantic area, the fastest moving area of medicine. All of hemonc is and nobody can know all of it. So we rely on each other. We also consult within each other within our academic setting. Like I have a meeting every Monday, and most cancer centers do have a tumor board, but ours is at a very high level. Where we'll have, debate between faculty members and our fellows will present and show slides. We'll look up the latest papers, and sometimes that's something that just came out this week. And we'll say, does this impact our decisions or impact our practice? And that's like one of the more intellectually satisfying areas of my work is that we can sit and have that kind of very dynamic discussion of like, what are the latest things in this? Does this apply to this case? Is this something that should generally change my practice? How good is the evidence? How practical is this? Could we even afford to do this? So that's a very fun area of my job. I like that. I like running that conference and sort of you know, uh, poking people to say, okay, how do we justify this? What's the data for it? Is it a practical thing to do? What's the unique thing we're going to do in this unique patient's case, and so on. So that's very, very interesting to me. The inpatient ward is, where we do most of that live in-person training and teaching with the whole team. So it'll be myself, it'll be a fellow, a hematology fellow, two second-year residents from the LA General USC system, and then usually two PAs or NPs as well. We have a very complicated service. People are very sick. A couple of people always in the ICU. So it's a pretty intense service. It takes a lot of good minds together to get optimal care. That's why they're sent there. People are flown in from all over the state and Nevada to us for this kind of care. And so that's it's challenging but interesting. I like the inpatient service because it is so intensive and interesting. And then I think we'll have a few questions about CAR T cells and stuff like that someone brought up. But I guess what I'll do here too is answer some of those questions. But let me just show you some of the coolest things I work with, and then we'll take on those questions because some of them relate to that. Um, so some of the areas that I work in, as I said, was immunotherapy. So I started out as being sort of more of a transplant doctor. I was interested in lymphomas, leukemias, multiple myeloma. And then my clinical trials were usually based on immunotherapy. The very first one long ago was the anti-CD20 antibody Rituxan used in all lymphomas now, most B-cell lymphomas. Then out came the antibody drug conjugates. And these are the ones where they'll use the antibody more as uh, a smart bomb. Can you see my screen? I think it says it so. Okay. And that was the one where I explained it, showed you that little cartoon that they keep developing new ones, and it gets very interesting when we get a new one to try out on patients and see if it works. And they tend to be not very toxic, so I always get uh, interested when these come along because they don't have a lot of off-target toxicity because of their specificity. They can just be sort of disappointing because they didn't work or something like that, but they don't tend to have like big surprise bad toxicities. There's other trials that I've written myself that, finally shared with the National Cancer Institute and so on is interesting. The other one area that's really interesting to us, but some of these get to be very powerful, so we really have to hold our breath about what kind of toxicity we're using. Some immunotherapies are like, you know, activating the immune system like it was in 2020 when COVID activated your immune system. It can be dangerous when you really turn it on full court press. It's like a nuclear reactor. And if you don't have those cooling rods in there to sort of control it, it can get quite dangerous. So we've had a lot of designer antibodies where the front end of the antibody sort of targets the tumor and the back end of the antibody pulls in a T cell to its target. And there's a lot of great ones that have come out just in the last couple of years and are fully into our clinical practice now for lymphomas and multiple myeloma. And they are amazing. I mean, they take patients who failed everything else and now are responding to this for years. So one of the diseases I focused on early in my training was multiple myeloma, which used to have a life expectancy of 3 years, and it's now 13 years. in my just last many years of practice. So it's very gratifying to see that progress. We've also learned a lot in the whole area of oncology about what makes the immune system ignore cancer, particularly as we get older, from decoying T cells to ignore them. And we come to up with this whole area of what are called checkpoint inhibitors that sort of break that hypnosis of our immune system and make them wake up and recognize their cancer. And that's been a big breakthrough in broad areas of cancer medicine, very exciting. And then, of course, CAR T cells are probably the sexiest thing we do, which is where you take the patient's own white blood cells out of the body, like we would for a stem cell transplant. We do gene therapy on them and transect the cells with a gene therapy cassette that will make the cells recognize their target, lymphoma or leukemia cells, and automatically activate and start attacking the lymphoma. And so these are very exciting because they can actually cure patients in settings where we never would have been able to expect cure. And my patient I said I go skiing with every year, that was his fourth line of therapy, and he has been in remission now for 9 years from CAR T cells. So it's sort of arming their own cells to go back in the body as super soldiers to find, seek out, and kill those cancer cells. So that area keeps moving along and is very gratifying. But we have a lot of successes in some areas and not in others. So it's still sort of art and science mixed together. So why don't I go through some of the questions, and I'll just do a few of the chat ones, and then we can talk about maybe just open it up for people who want to raise their hand and speak their questions. So aggressive B-cell lymphomas, how do you decide between second-line CAR T and salvage versus transplant? That's based on their chemo responsiveness. And we now have a lot of really fancy new markers, which you mentioned next, biologic markers that are looking at circulating tumor DNA. So next generation sequencing has been a really big breakthrough. You might even hear about it in the regular news because now we think we might be able to do blood cancer screening very broadly, which was just sort of a pipe dream 5 years ago, because we can pick up these minute amounts of circulating DNA with unique mutations in them from a whole variety of cancers. And that is starting to be applied in general solid tumor cancers, but we're starting to use it very specifically in blood cancers to monitor, did we really get this disease all the way into remission down to 1 in 1 million cells? That's what that circulating tumor DNA test would tell us. Not just did the PET scan look okay. And that tells us also when it comes back, how well are they responding to that salvage therapy, chemotherapy? Should I go to transplant now or should I go to CAR T? That has really changed just in the past 2 years. I run the auto transplant program for USC, and that's the most common type of transplant, more common than the allos. And I now have to make that decision like, okay, this patient was really sort of resistant and they came back within a year. That patient's going to go to CAR T. This patient spent about a year or they already got some salvage chemo. They responded really well. If they respond all the way by their scans, I might take them still to an auto stem cell transplant. So we have bispecific antibodies also for the patients who've either failed their CAR T or they can't go to CAR T or transplant because they're not strong enough. We have a lot of patients who are in their 70s and 80s, and they're not going to. I have done CAR T cells on someone up to in their mid 80s. So he just finished hiking 100 miles in Australia, so I figured he was strong enough to do it, and he did do fine. So that's a long conversation how we sequence these things, and we give whole lectures on that. But we have strategies, and they change over the years as new successful therapies come out. I think I answered the one that Nina asked. We don't have to agree on our management. I could only make recommendations, but they've usually called me because they want my help in giving them the ideas of what we can do next. Um, in the university setting, the question of trainee autonomy, this is the question from Juan, about versus patient safety. Well, that's always a very interesting question. We had a lot of autonomy when I was training in a very famous university hospital. But it's a balance. The patient, the resident is with you as a patient day and night, and they have the advice of attending, but they're also the one who knows you best. And so you have a team structure, though, right? So you've got advice at multiple levels of how to take care of that patient. You've got the attending who might be only a specialist in their disease, but you've also got your senior attending who might be a much more sophisticated acute care hospitalist in terms of their knowledge set. You have your In my case, my team, my PA, who knows that patient from three prior admissions and knows some unique things about that patient, says, "Oh, wait, but I remember 3 months ago they had this problem," and nobody else on the team knows that. And that's like a key piece of information that helps us make better decisions. So I would say that the thing that helps us balance our individual decision making with the patient safety is the team structure itself that allows multiple people to provide their expertise to it. The clinical reasoning skills I find most difficult for residents or fellows to develop in HEMOC are um, really learning to focus on individual problems, generate a differential diagnosis, and not just jump on their favorite diagnosis too quickly. It's very easy for people to say, "Oh, I think it's this," and they'll forget about everything else and even dismiss data that would argue against their diagnosis. So having not falling into bias too quickly, and I don't mean like social bias so much as even scientific bias, to not just get in love with your first diagnosis, and also to be thorough and conscientious that you're leaving no stone unturned, that you've thought about everything that's going on in this patient in case there's something you didn't suspect or think about from the main diagnosis. Um, how do we teach trainees to manage uncertainty when evidence is evolving rapidly? Well, we all have problems with this, even the most senior of us. Like I'll bring up to my patients, "I'm going to talk about you in my conference on Monday, even though I'm the most senior person and I'm the person that everyone comes to with their questions. I want other people's opinions. I want a fresh set of eyes to look at this. I'm going to get you, 6 independent opinions on this because we have a really good collegial group where people are not afraid to speak up with their difference of opinion, for good care of patients and good science too. You should be unbiased and willing to listen to someone else's alternative hypothesis, if you want to make it that, to make sure you've really thought about this from all angles. And there's a lot of just unknowns in medicine. I think that's sometimes difficult for us with the American population in one sense has great faith in medicine and science, but almost too much faith. They think sometimes everything has an answer, or everything is diagnosable, or everything's fixable. And sometimes it's, our people, the public's expectations of what we can do is always a tiny bit ahead. We keep making rapid progress, but their expectations are always even a little beyond what we can realistically do. So managing that uncertainty is sometimes just by constant renewal and discussion and sharing of information together, and again, that kind of team and collegial discussion. Um, what teaching helps learners understand the transition from guideline to individual? That's the group discussions, our team-based rounds, as well as our weekly discussion of the more novel or complicated cases. I think getting multiple inputs on it allows us to nuance, okay, the guidelines say this, but this individual person's circumstances, I think, justify going this approach. The guidelines are never that perfectly rigid either, though. Okay, so I have a couple questions there from Juan, but I'm going to skip and go to someone else here to get another one in there. Um, and so Eva said, how often do you have issues with insurance companies? Oh my God, interfering with treatment is like every minute of my life. So for example, we have a mixed blessings in California. It's a very, fully committed ACA state. So everybody gets insurance in California. Every human being can be insured in California. And that's great, except that it's splintered into a lot of very variable small HMOs, Medi-Cal subsidiary HMOs that are very um, unpredictable in terms of what they'll authorize. So I think one of my biggest ethical distresses in my job is that I have three people with the same disease, the same scenario. One person's getting immediate care, because they have Medicare or a good PPO, and another one is on the same HMO, and they're getting different care across the street at one hospital than they're getting at my hospital. I the same disease. And what's tough for me is a lot of people in Medi-Cal are not just necessarily economically a little, more challenged, but some of them are just young. Younger people don't have big jobs yet that have big insurance. And it seems sort of paradoxical to me that we have really very liberal insurance for people my age, But someone who's starting out, maybe supporting his whole family and his older parents, is getting very compromised care because he can't afford that, higher level insurance or isn't even offered it through his country. So the inequities in insurance really bother me a lot. And I would love to see some more universal or more uniform form of healthcare in our country. I would love it, for example, if we could just have Kaiser for most people. Kaiser's great insurance, and um, I think Americans might, accept something like that. If you're from California, you know what I'm talking about with Kaiser. It's a really amazing program, but um, nothing's perfect. But we talk a lot about economic and socioeconomic and ethnic disparities in care, but so much of it really comes down to just access to insurance. And I feel also that we're coming to a time where we might need a little political advocacy to um, make sure that a patient with a new diagnosis of cancer has at least an opportunity to go once to a cancer center to get an opinion. And I don't even call them second opinions, a consultative opinion from an expert on their disease. But I'd also really like to, if I took a sabbatical or retire anytime to do this, would really like, there are some states that are starting to have laws about how long an insurance company can take to authorize something. And I just think it's incredible how cancer patients sometimes are left hanging for weeks to months, not getting their PET scan, not getting their chemo started, not getting sent to an expert that they need to see because it's beyond the level of their local medical group, and it's really tough, to see that. It's paradoxical that like the whole state of Nevada's Medi-Cal group is called Health Plan of Nevada. They get very uniform care. They have like a system. They send them down to us. Those patients can get pretty on the ball care in a timely fashion. Everybody in Bakersfield, the central part of California, they have this really good HMO, Kern Family Care, and they take care of their patients. They arrange their transportation. They say yes to the things we expect them to say yes to. They do it in a timely fashion. And then you get to LA and there's like 20 subgroups. These people are walking distance from my hospital, but not allowed to see me, for weeks to months. It's paradoxical that the people from the less sophisticated areas that are referred to us are sometimes, I think, getting better HMO care. So that is an everyday challenge with the insurance companies. I'm glad people have insurance. It's better than the days when people were uninsured, but sometimes barely. Okay, my definition of a successful outcome has changed for sure. I'm still gratified to see people cured, but the tough cases that I've helped them live longer or better is still a success to me. Um, Maria asked, how do you communicate difficult information to patients, such as treatment that did not work? We were just having a meeting about that earlier today. That's something you gain by experience. I have many, many years under my belt, and every human being processes information differently. There's family dynamics to take into account too. There's family opinions that get in the way. I'd say one of my most difficult ones in recent weeks or months was an older man who was just not doing well. There was a possibility that further treatment would help, but he just was declining. And his daughter was there with him every day, all day long in the ICU, and was very, very sad, on the verge of tears every day, but you really understood intellectually in spite of that when we said, maybe we should start backing off some of these interventions. We don't seem to be getting too far with it. And he seems to be sort of not looking forward to any good quality of life. And then outside family members came in and just immediately started really sort of viciously criticizing her for making some of these decisions and advocating for him for his, comfort and quality of life. And they hadn't been anywhere to be seen in all these weeks I'd been taking care of him, but they come in and criticize the person who'd faithfully been by his bedside and very emotionally attached to him, and just trying to help her stay strong through all that criticism and stand up for her dad was something I felt also felt both sympathy for her, but also felt gratified that I could reassure her that she was a good person and a good person for being strong to stay by his side and stand up for the decisions that needed to be made. So sometimes you get in the middle of these very difficult family dynamics that are a little bit challenging. And what changes in oncology practice have affected how I treat patients? Well, on the good side, all the fancy, incredible new immunotherapies and so on I have to offer them is very exciting. That's a question from Gabriella. But the other changes that are difficult are the constant changing of the insurance and financial environment. I am really um, a bit distressed by the fact that, medicine is so money driven these days, and it's really the corporatization of medicine. Some of it's necessary. It's a very expensive, financially risky area, but um, I, I feel like I went to medical school to take care of people and give, my best intelligent intellectual input into their care and my best self in terms of the emotional and psychological care of my patients. And I just really don't want to, have finances constantly hanging over me and the decisions of how I make proper care, take my best care of patients. So that's a bit of yin yang for medicine, and there's a bit of an article on that in New England Journal today, I think this week, about the corporatization of medicine in America. I'm sure it's very different in Europe. It's not all perfect there either. There's a lot of other restrictions in Europe, but they also take a much longer global view of the patient's life and their financial and medical commitment to that patient. The German system or the French system is looking at how am I going to take care of this patient over 10 years, and what is the cost effective way, but also the best way to take care of that patient. Not just is this patient only on my insurance this month and maybe I can get rid of them in January 1 and not have to pay for that expensive drug, which is extremely short-sighted and not at all compatible with good medical care. All right, I think then I'll look at some other questions, but if anyone wants to raise their hand, we can also take verbal questions. I need to take a sip of my coffee and notice my voice getting rough. How does the antibody? One question was a technical one from Samiksha. How does the antibody release the chemo? It's very intelligent. We were doing antibody drug conjugates when I was a medical student or resident, and they would fall off too soon and make the patient sick. So they've learned about linkers that will only detach in the lysozyme environment inside the cell. So it's really pretty cool. It's an enzyme that breaks the link. How's medical education changed? Well, good and bad ways. Over the years I've been teaching, lectures have been sort of de-emphasized. A lot of medical students don't come to lectures, but I think they're mistaken in thinking that they don't need to, because I'll give you an example. People who are very more advanced in their practice and in their, practice and tending years. We learn a lot from web-based programs, non-interactive programs, and so on too. But when we go to our national meetings, most of us go to our national meetings. When they put them on Zoom, we thought, oh, this is cool. You don't have to travel in December to, Orlando to go to my meeting. I could just sit in my living room and do this. And there are advantages to that. Like I like that my Monday meeting is on Zoom because everyone's all over campus and they're really busy and everyone was always late before. Now everyone just stops and jumps on it, right? And it can be quite interactive. But I find that only, 4 people interact on it, and the other 28 are just silently listening. And maybe it would be more interactive if we were face to face. We still require the fellows go to at least 2 of their weekly sets of conferences in person and sign in because uh, if you study anything about memory formation, it is stronger if you have more stimuli, you form more synapses. So the same lecturer that you see live giving the same lecture, you'll still remember more, and your performance on a quiz after it will be higher if you had a live experience. So I think we've de-emphasized the live training a little bit too much. And people are getting, I know that coming back to that example of national meetings, a lot of us realized after that year or two after COVID, like, we're not really getting engaged with this material. And all of us started going back to our meetings live. And we go into that meeting room live. Even when you have an option of just watching it in the remote room, you're like, you know what? My mind is drifting. It's literally like, why do you go to a live concert sometimes? The experience is different. You're feeling the intention, the vibe of the other people in the room learning. And the likelihood of people asking questions and really perceiving and experiencing those questions and answers and the discussion is just so much more fluid when you're doing it live. So I would encourage all of you to do as much of the live experience as you can. It's really, really very different. How about some of the young patients following your treatment when they share the treatment with family and the family do not allow treatment of that's the best treatment? We do get sort of opinionated parents and so on. I only treat adults. That is a bigger challenge. The pediatric oncologists, they actually, with things like transfusions, if it's some people have religious beliefs against transfusions, the parents, there's actually the pediatric hematologists, if they get a leukemia patient, have to override that and get a court order for guardianship. But it's not usually that dramatic in my field. I point out to the parents, if a child is, it's their child, but if they're 18 years old, they are my patient. And so, at a certain point, I may have to excuse them from the room and talk to the patient directly about what we need to do. Um, but most of the time the family is very helpful. I do have some that are less so, like this older man I just saw yesterday, where, everybody in the family had opposite opinions about, don't do treatment. Someone we know died of their cancer treatment, and do treatment and don't do treatment. And he didn't want to do treatment. And we did have a lot of comorbidities. So we ended up asking permission to use an all immunotherapy frontline regimen. If his insurance allows us, that probably will be a lot gentler and won't seem like chemo to him because it's more targeted. Is there advice that you wish you'd been given when you were starting out? I think I felt pretty comfortable with how I went through this whole path. I guess what I give as advice is that sometimes people have a hard time visualizing what will be satisfying to them about their career 5 or 10 years from now. So for example, I see a lot of my residents going into hospitalist medicine. I see very few people going into primary care. Um, and I sort of want to tell them, don't just look at what your experiences are now in residency, because residency is very artificial. It's not really like what you're going to be practicing in 5 or 10 years. And the human connection with your patients, the longer term connection, and with your staff, the people you work with being a stable group. I've worked with my nurse practitioner for 12 years. I have other people in my workplace that I've been working with for 20 years. I get a lot of most people get, spend 40 or more hours of their work life in all fields, not just medicine, with their work colleagues or co-workers, and having a good workspace where you enjoy looking forward going into talking to your people that you work with in your clinic or your workspace is half the joy of working. I remember once comically noting that who were the grumpiest people around in the medical environment. It was usually the doctors were the grumpiest, and then the nurses were like, medium grumpy. And the happiest people in the hospital were like the guys in medical or ladies in medical records. And that's back when they used to have paper charts. Like, why are you guys so happy all the time? And they liked working with each other and they liked being helpful to the doctors and nurses. And their job was so simple, but their expectations of their job were here, but they just enjoyed the interaction of who they work with every day. And that's a big part of your lifetime career satisfaction. So, I do warn people like, oh, that shift work looks great, but you still want to work in a stable setting where you'll really get to know people over time and have that satisfaction of the longer term human interactions in your workplace. Um, okay, throughout your career life, how do you usually overcome challenges or unexpectedness in your specialty? Well, that's a question from Kristen. A lot of it is talking to your fellow, and I say colleagues, I'm including my nurses, APPs, my um, uh, other fellow physicians and trainees. You sort of talk about things that I remember I was just really dumbfounded one day when a patient of ours that had gone through transplant and had an unexpected complication and, almost went into complete liver failure, and they took him across to another more specialized ICU and really pulled him back from the edge. I was so excited. I talked to my oncology colleague that it was his original doc. I said, "Gosh, it's so amazing. They pulled him back from the edge." He's a young guy. He was super nice, the patient. And she goes, "Oh, you didn't hear." And I was like, "What?" And I'm standing in the hallway and she goes, "He died this morning, unexpectedly." Like, and I was like, and I have to go walk into the next room and see my next patient. So that's hard. You have to, sometimes you need like, whoa, I just have to put that aside artificially, go talk to my next patient. But later on that day and the next day, I talked to all sorts of people, my family, my friends, my colleagues. Like this was just, I'm supposed to just keep a straight face and go into my next clinic appointment, when something so unexpected happened to me. There's a lot of external changes in medicine that get us really frustrated and mad, and we sort of commiserate with each other. But we also took action. I sort of led led my medical group to go to leadership and say, you're not showing respect to your physicians, your highest level professionals, and people are leaving because of this, and you need to. I can be very blunt and tell, speak truth to power sometimes because I don't want all my younger colleagues to lose, hope and just leave. So, I went and really got us together as a group, presented our case and say, you need to listen to us. And we sort of ultimately turned it around. So that felt both challenging but gratifying to advocate for that. I'd love to have time or ability to advocate more on the patient's behalf because I really think there's a lot of political work that needs to be done with our extremely messy healthcare system. I don't like, I like remote work only for things like this. I'm not a big believer in telehealth. I like the direct patient interaction, particularly in my field. Patients have very intense medical problems and they're also very worried. So they aren't going to feel very reassured unless they see me in person. So I just do telehealth to say, okay, we're going to follow the PET scan's happening 3 days from now. So let's do a quick telehealth so you don't worry all weekend, about what the result is or what we're going to do next if it doesn't show what we want to see. So I use it tactically, and I think for some fields it's great, like a lot of diabetes management, telehealth makes a lot of sense. Why should they come all the way in to just talk about the numbers? But my field, I really have to take care of the whole patient here. So I use Thursday as catch up. I have to do all that billing, do all those notes, think about that patient, think about what I need to do next, do my meetings, and get some of the thought put onto your research work. Are you caught up on those protocols and so on? So you always need some non-clinic days to catch up, and those are usually easily done remotely. Artificial intelligence in medicine, how's it impacting my work? It is mostly beneficial, mostly beneficial. Just you can't believe everything you read, right? So you have to check your sources against each other. So for example, when I'm dealing with something I haven't treated for managed or worked up since, I was a resident or something like, what's the current laboratory workup of polycystic ovary syndrome? Because it's not my field, but I have a patient where I suspect it. And it'll give me an answer and some references, but then I'll go cross-check it against another source, and say, because there are definitely some inaccuracies in artificial intelligence, but I think it gives us more rapid access to very complex medical information. Particularly, I haven't yet started using more focused AI platforms, which I think I should. And so I think it's mostly going to be beneficial. I think there's a lot of knowledge out there in medicine that is expanding at, literally light year pace. So the only way to keep up with that is to get sort of the first layer of information you can get quickly by AI and, using your Gemini or ChatGPT type sources. But you just do that to sort of start focusing the information that you need to explore. I'm still probably going to read the article and look at the data and look at the graphs, and see is that really, and how exactly did they give that? And what were the flaws in that paper and so on. So I still have to drill down into it, but it gets me more quickly to the starting point, I would say. What's the most rewarding aspect of training fellows in blood cancer? The most rewarding thing is when they're really excited about it and have a lot of intellectual curiosity. About a week ago, two of the fellows was after 6 and so on, and they work long hours and they were just staying to ask me about questions and ideas about how things work, in the hallway, for no reason other than their own interest. And that's what you really want to see, someone who's like spontaneously excited about the field and learning about it on their own. So, aside from just seeing them out in practice, and when they call me up when they've already been out in practice for a couple of years and they say what they're up to or show that they've gone on to an academic position, both of those are fun for me to see how they're coming along in the rest of their career. Okay, so Vani has a question. Seeing death can come with additional support, such as therapy, religious heads, or even leave. Do you see this similar in hospitals like oncology, where you may see a lot of death? How have you ensured you remain positive, knowing you've done your best? Well, this is actually the topic we were having at noontime for Medicine Grand Rounds, was how um, this person was analyzing how intensive end of life care varies between intensity of hospitals and between countries, mostly focusing just on, um, highly industrial Europe and the United States, because there's just even a world of difference between the United States and just England or Germany in terms of what people expect to offer or not offer, because of the, high focus on individualism and autonomy, sometimes leading us to do really excessive things near the end of life and being afraid to sort of challenge that or question that in the United States. Very interesting area. Um, and what I see surprisingly little of is involvement of any spirituality in these discussions. It's sort of left to the family if that's their thing, but physicians never ask a patient, do you have a belief system? How does this influence, what you're thinking about in terms of how you feel you're doing in this late phase of your disease? We never have those conversations. We don't get any training on it either. And I find that sort of a glaring absence, given that we're talking about death. And, you know, it's not like the majority of folks in the United States are atheists. So the fact that we don't talk about that is amazing to me. Um, I really do appreciate the palliative care people as a growing specialty, that they help us with that. But I also have a strong feeling that if I've been with this patient for years, I'm not going to just suddenly say, "Oh, well, I don't have anything more for you to do for you. I'm just turning you over to the palliative care physician." Like that's not my job anymore. I really, the longer I've known the patient, the less likely I am to use palliative care, because I feel like they have built up a relationship of trust in me over the years, and that they have to feel like I'm addressing their needs as someone who's known them and taken care of them all this time. Um, and you're right, it's not very similar between hospitals. It's sort of a little bit shocking. There's not a lot of inpatient oncology anymore in a lot of hospitals. There's not that much. What concerns do I have treating someone in their mid 80s? I have a lot of people in their 80s. We really focus much more on fitness these days in the United States. And also, we used to say, oh, well, that person probably doesn't have 10 years to live, but that really depends on their family history, right? So um, I have 84-year-olds who've done a lot better than 55-year-olds. Our relative health is not just age related, but fitness related, and also what their goals are. Some folks in their 80s and really will be willing to try new things, or do something that might be a little difficult, but ready to back off if it's not going well. And I have folks who are afraid to start treatment, who really should be doing treatment, would have a high benefit ratio and so on. Um, how has detecting 1 in a million cells changed your treatment timing? What did you do before these tests? Well, the tests aren't really quite there yet. They're just coming into availability. We use them a lot in leukemia. And they've changed a lot. In acute lymphocytic leukemia, the ALL patients, we use that testing now absolutely routinely. That's not a common disease. It's only 2,000 adults a year, 2,000 kids. But we go right over to immunotherapy in those patients that are positive. We have some patients now that don't need transplants because we can tell that they're really clear down to 1 in a million cells. So we can hold off on transplants, which is wonderful, not to have to do it blind. But it hasn't really yet gotten all the way into the other areas of our practice in blood cancers, and that blood cancers is where it's going to happen, because we don't get that kind of depth of response in most other cancers. So, um, You were wondering about things from a physician, saying you've heard a lot about burnout. So burnout, I would say for a lot of us is from challenges of feel it's not that we feel our medicine isn't satisfying. It's usually the superstructure of systems that expect you to see too many patients with too little relationship, or people feeling that the financial structures are overriding their ability to practice good medicine. And also, American public is getting to be quite a bit more difficult to deal with. And I know it's hard sometimes to keep your perspective that, maybe 1 out of 50 patients is really in your face. But it really does start to wear on you a little bit. The Americans are really getting to be very difficult. And our risk management and legal people are really seeing a lot of uptick in this, and people are like screaming at doctors and nurses because of a, I don't know, refill question or something. And we've had a large uptick in people where we just have to dismiss from our care and so on, or have behavioral contracts with them and so on. So that can wear people down, lack of appreciation or overt antagonism from either their business office or from patients themselves. So um, I also think that some of the burnout is a lot of us do resent, and there's a lot of pushback of implying like, oh, we're supposed to just go meditate or, do yoga to deal with our burnout. No, it's about systems. It's about the EMR. It's about the non-meaningful workload. How many hours do you spend clicking on your computer? That's an area though where I think AI could come to help. In the old days, you would just have maybe your nurse, or let's say in a business setting, your administrative assistant secretary at your side, and you just say, okay, can you order this, this, and this, and to get that done and get this authorized, and they would be like the go-to person for doing that. And I think AI could do that for us. Like I'm sitting and clicking for hours to bill a week's worth of inpatients. Why can't I just talk to my computer and say, read the list and bill this way, bill this that way verbally, and be done with it? So I think AI will actually start to turn that around, where the really menial tasks of medicine that get us burnt out, and that is what most physicians do quote as one of their most largest contributors to burnout, is the amount of meaningless work we have to do. EMR, billing, calling insurance companies, waiting for authorizations. That all could be very, very streamlined by AI. I think that could be done tomorrow. It's not being done fast enough. Okay. What made you choose hemonc over the other specialties? Back in the beginning, when I took that blood course, and I got very fascinated by the immune system, and it's turned out immunotherapy has been the big, big thing in not only the blood cancer is very, very much so. Like we're completely replacing chemo in whole areas of my field with immunotherapy. But also in oncology, it's becoming extremely impactful. The immune system is very, very important there. All right, knowing what you know now and having been a doctor, if you could go back in time, would you choose? Yeah, I would. And in fact, um, a lot of us have said if we could just practice medicine and not have to deal with any of the other aspects of it, could we just practice medicine and be a doctor? Most of us would keep practicing indefinitely as long as we were useful to people. And we just like to get rid of a lot of the other junk. And it's possible too. It's just sometimes people get a little burnt out before they can deal with it. Some people, sometimes you just get bored too. I'm not, because I'm in a very highly interesting field of medicine there's always an exciting, new thing going on. But I have friends who've had more routine practices, outpatient, OB/GYN, and they're just, they've done it for 35 years, and I'm ready to stop now. And so that's okay. Have you ever regretted not pursuing veterinary medicine? No. I think I find it more gratifying to treat people, but that's why I'm glad I chose medicine. And my daughter chose medicine. So my daughter's an emergency medicine resident. I do worry about burnout in that field, but she's very excited about all the variety of it and everything too. She's definitely living the life of the pit. The pit is highly, highly accurate a depiction. And how do you decide how much of your career to devote to research versus clinical care? Um, Research is gratifying but slow. You get a lot more immediate gratification from the patient care. So That's why I sort of like clinical research. It's something that's sort of enhancing my clinical care, but I didn't have a lot of patience for the lab research because you've got to be super patient for that. You know, 90% of what if you do won't lead to anything. That's sort of like being a screenwriter in the movie business. A lot of those things are never going to come to fruition or never get funded and so on. So it takes a much higher level of patience. I get a little addicted to the constant stimulation of the clinical area. Okay. Anyone else want to ask live questions? Put your hands up or just unmute.
Oh, there was a question I asked. What advice would you give your younger self starting out?
Um, Well, I think we worked really tremendous hours. When I trained, it was 36-hour shifts every third night. So we actually worked 110 hours a week when I was training, which is by regulations not even allowed now. But I think I kept pretty good work-life balance, meaning I would work hard, play hard. I would always get outdoors. I would always meet with friends and keep friendships going. But it can get, I guess if I was gonna give advice I to my younger self. I don't know. I'm not completely regretting anything that I did in my prior younger career. I have more advice that I wish I'd give myself now. Like not get upset about certain things or get cynical about things. Try not to be cynical. Um, how to decide how much to devote to research versus clinical? Well, it was just sort of circumstantial. It was I was more needed in the clinical area, and saw, sort of people started coming to me for the clinical trials, and that ended up just being more interesting to me. If I could give some advice to all of you, I do think that a lot of people do get focused on, oh, I want to be a doctor, like because we just, our colleges are very oriented towards the pre-professional tracks and everything. Lawyer, doctor, MBA, it sort of gives me my credibility or something. But there's so many areas in medicine where you will find satisfaction and are helping people and also even getting very involved in research. I try to tell people to think of the health professions more globally. There's amazing things people do with nursing degrees these days. I think actually nursing has probably the most flexible variety of career paths that you would never imagine until you go out and talk to like 40 nurses. Some of them end up being NPs and being super specialists in my field. I have NPs that were ICU nurses before, and now they are like a super expert in allogeneic transplantation. Like they know way more than I do in that field. And PAs too, are just an amazing addition to our field. And the two of them often working closely in parallel and learning from each other. Our pharmacists are incredibly important to us. We have like very specialized pharmacists and research pharmacists, and they do an amazing job. And they are my immediate partner and people I talk to like multiple times a day. And we get all excited about new things. And hey, we could try this thing. And how are we going to do it? And you're going to help me do it safely. There is really, really strong partnership between all these areas. And even, all there are just, nurses and non-nurse staff that end up learning sort of niche things that really, really help our patients. The social workers are incredible. All of that is healthcare. And so I hope people don't just focus on medical school as the only way to, have a gratifying and meaningful career in medicine. It's very hard. I think the one thing you do have to ask yourself if you're applying to medical school is it is a very, very long years of delayed gratification, and it takes incredible self-discipline. So you have to really think if you want to devote that large a portion of your life doing this. It's not the only way to get into a very, very satisfying medical career because I have a lot of family and friends of friends, kids, and so on are applying to med school. And it's great if that's, if they think that's what they really want to do. Make sure you've had some live clinical experiences and see what the real life experience of it is. But also remember that you can make an incredible contribution in medicine by all of those allied health fields and really be intensely involved and part of a very, very engaged team to do fascinating things and take good care of patients. So don't Don't just focus on the one thing that society tends to put out, on the little hat that people wear of lawyer, doctor, businessman. It's a long path. It's a long path, and it's worth it to a lot of people. But some people are already burnt out by the end of their residency. I guess that's an advice I have to give. Some it's just such hard training for some people that it barely seems worth it when they're just finishing when they're in their early, late 20s or something like that. So don't be afraid to explore all those sides of the healthcare professions. They're all, have pathways to being really productive, useful, very meaningful healthcare careers. What made me want to become a doctor, choose that path over becoming a nurse or PA? Well, PAs didn't really exist back when I was training. I was always into science and so on, so I always had a research interest and so on, and knew that I would probably do the long path. But it's not for everybody. All right. I'm going to take
I just had one final question,
sure.
and then we can wrap up. What's one problem in multiple myeloma that you wish that you could just solve?
Um, well, when patients in multiple myeloma often involves the bones of the spine and causes a lot of fractures, spontaneous fractures of the spine, leaves people sometimes paraplegic or barely able to walk, or breaks other long bones like the femur and the humerus. So I wish we had 3D reconstruction of bones and vertebrae and discs so that we could reconstruct people's spine and get them back up and moving better, because that is it's later stage in the disease these days. But some people start out, like I've had men who are like 6'3" and athletic, and they lost 6 inches of height from their myeloma collapsing their vertebrae, and can't go to the gym or anything anymore, and sometimes really, really compromises people's lives. So it'd be really great if orthopedically, if we could reconstruct and re-expand some of those bones and help people walk again. That's just a practical issue that impacts their quality of life so much.
Right.
Scientifically, we're doing really well in that field, but biologically, but we can't remake a spine, and some people are so damaged by that.
Any final questions before we start wrapping up?
So why CD20 for B cell therapy? Is it because CD20 is like not memory B cell, but like just the aggressive type? Like,
No,
oh,
it's on
why
it's on the
this
low
one?
grade types as well. It's a universal mature B cell marker. So it's
Oh,
a very uniform target that almost all 85% of blood cancers are of B cells, and 90% of those are going to express CD20, so it's a very consistent target. CD19 is also there, but that's the target of CAR T cells. All right, I'm going to wrap it up here. Do you need me on some last slides, or do you have other things you want to have them do for their survey and so on?
We just have reference slides for live sessions, and then anyone can stay back if they have any additional questions.
Okay,
Okay,
have a good one. Take care.
thank you. Okay, so here are just the wrap-up slides of PHS. I'll make it quick. So three questions I have for you today was, what are your favorite moments from today's session? What's one idea from today that you're most excited to explore next? And what's one key to a takeaway you got? And feel free to answer these questions in the chat or our PHS reflection. Also, feel free to share your insights on LinkedIn at Pre-Health Shadowing, and that's linked in the chat. And once again, if you're interested in being part of the pre-health shadowing team by either volunteering or joining our leadership team, it's 100% remote, and you can sign up for it using the VHS website. We would really appreciate any sort of donations from you guys, whether that's through money or donating your precious time with us with volunteering. Don't forget to take the digital certificate for attending today's session. It's also available on PHS website if you click Dr. Ann's name. And it's just a 10-question multiple choice based on the presentation, and you get 90 minutes worth of volunteer time. If you miss any part of the session today, you don't have to worry. The session gets posted on the PHS YouTube channel, and you can just refer it to there to get the questions. Make sure to sign up for our email list and check our website to check our sessions every week. We have 3 to 4 sessions every month. Thank you so much for joining, and feel free to stay back if you have any questions.
Hi, just want to check about the reflection questions,
Mhm.
whether they will be something which are a part of the quiz, which we'll see later on with the
Yes.
certificate. Okay, cool. Thank you.
Mhm. Does anyone else have any questions? Okay, I'm gonna end the session. Thank you, guys.